Okay, I'm starting by palpating the sacrum with my right hand and then palpating the posterior iliac crest with my left hand, figuring out where the piriformis is coming down from the sacrum out to the greater trochanter, and then in my mind's eye envisioning where the sciatic nerve travels underneath the piriformis and down the leg to the foot. So today we are talking about sciatica, piriformis syndrome, and all the issues that can show up and look like sciatica, feel like sciatica, and how we can help. As I start warming up my client's low back and hip with some compressions, you might notice that my client has clothes on, and the reason why I'm doing this is because it's pretty difficult to demonstrate all of this stuff with the veracity that I do it when I've actually got a client on the table, only because filming can get a little technical, and I wanted to be sure that you were really able to see all of the work in detail without me fumbling with the drape. As you can see, I've moved away from compressions and into friction, and you can do this with a tiny bit of butter or oil or lotion or whatever you use, or with none at all. But the point is that this area is very thick with connective tissue. There are a lot of attachment sites and a lot of ligaments, and using a little friction to create warmth in this area is going to allow you to be able to sink into the muscles a little bit better, and it's going to allow the SI joint and all of the tissues that cover the sacrum and the hip to soften and ease up. I'm also starting with a slightly faster pace than I usually work with, and the reason being is because with sciatic pain, piriformis syndrome, and similar complaints throughout the hip, there is often a deep holding pattern that I try to address right off the bat. I'm going to talk in this video a lot about the difference between pseudo-sciatica and true sciatica. And of the two, the one that we as massage therapists can help with the most is pseudo-sciatica, but I'm going to treat the entire area as if there is a tension throughout the low back all the way down into the hips. So to start off with, I'm sinking my thumbs down into the sacrum and pushing it away from the spine. So understanding exactly where the spine is right there and its relationship to the sacrum and to the iliac crest, I'm sinking down right into the SI joint and just above it and pushing down away from the spine, allowing for some opening between each of the lumbar vertebrae and giving the muscles that hold this area from the low back a little bit of space. As I start to dive in a little bit deeper, it's all about connecting the relationship between the posterior hip and the low back for my client very specifically. So as I start to focus a little bit more intensely on the QL, I'm going to compress down into the upper glutes, and that does two things. Number one, it creates a distraction away from any specific work I'm doing into the QL, and number two, as I sink in with my right thumb and use my left hand to compress into the glutes and push the hips away from the QL, it's giving my client a lot of understanding of that relationship between those two areas of the body. They are deeply and often highly dysfunctionally connected and have a relationship with each other that is a stubborn push and pull. So as the QL tends to tighten up, the glute max and the glute medius will start to guard and stabilize around the hip, thinking that there's something wrong with the low back. So this entire area can start to tense up and create sciatic type pain without there being an actual pinch of the sciatic nerve itself. I've switched the focus of my left hand to hook into the greater trochanter, and as I push it down and away from the lower back, I'm creating a nice little pin and stretch for the QL. So I'm using my right thumb to sink in as I create length in the QL, and then I can reverse that move and use that to my advantage too. So to flip it, I'm pushing the greater trochanter up towards the hip, and instead of creating space, I'm creating a softness. So as the QL gets softer, I can sink in and get a little deeper within that muscle. You can definitely pick one of those techniques, or you can use both. It just depends on what it feels like your client is responding best to. Moving inferiorly away from the QL and focusing my attention a little bit more on the attachments of the glute max and the glute medius, I'm going to use my thumbs to sink in just inferior to that ridge of the posterior iliac crest. The glute max and the glute medius have very strong attachments along this bone, and I want to start to soften that up so the work that I do in the posterior hip later is a little bit easier. I've been supporting one thumb with my other thumb, but if this gets a little bit too hard, you can switch to a soft fist. I'm also going to slow it down a little bit here because as I sink in with a broader point of contact, the work can be a little bit deeper. So it's important to be able to get the client to relax into that work to ensure that the depth is productive and not creating even more of a guarding response than the one you're trying to unlock. I have found that there are two major spots of tension when it comes to pain around the SI joint and the sacrum. The first one I worked on earlier was just above the SI joint, kind of where the QL comes down and attaches in. And the second one I'm working on is on the other side of the iliac ridge, just lateral to the sacrum, about halfway down. So sinking in there, I'm going to do a little more work into both of these points later, but for now I'm focusing on frictioning it through and allowing these tissues to melt away from their attachment sites and release their grip. So if your thumbs are getting tired, it's absolutely okay to switch to using your fingers, and you want to always support one hand with the other. This is going to save your tools in the long run for sure. A lot of people ask me if I use any kind of external tools, and I just don't. I can't feel what's going on, and I think especially here in the hips, that's a really important factor. So to help protect my fingers and my thumbs for this next move, I'm actually squatting down so that my wrists don't get compromised. And from this position, I'm able to really grab the tissues on the lateral aspect of the hip. Up a little higher into the hip, I'm able to grab onto the glute medius and the glute minimus and petrissage them away from their flat attachment site onto the posterior ilium. And then as I slide down a little bit farther, I'm actually grabbing the greater trochanter and starting to shake the hip joint itself loose. So as I grasp the femur, I'm thinking about my fingers and my thumbs sinking around the greater trochanter, and I'm jostling it just a little bit and asking my client to let go of her hip. A lot of the pain that people perceive as sciatic pain is felt down the lateral hip right in this area, and the sciatic nerve doesn't travel through this area. So if somebody's complaining about sciatic pain and they're pointing to the lateral hip, it's definitely more about tension into the attachment sites around the greater trochanter and the deep 6 lateral rotators, the glute medius and the glute minimus, and thinking about what's happening that's dysfunctional in this area as opposed to what's happening with the sciatic nerve itself. I've slowed my work down a little bit, and I'm focusing my energy a little bit more on my thumbs pushing into the TFL, into the front, lifting the hip up away from the table, and just presenting a movement to the internal structures that they might not have felt for a while and allowing them to get used to a little more space. And magically I'm standing on the other side of the table. So there's a couple things at play here. Number one, my body mechanics. So instead of squatting down and leaning into the work, I'm reaching across my client and I'm able to lean back while I'm doing this work. I'm really kneading through and making things pliable in this lateral hip. I'm continuing with the same work that I was doing before. And the other element is that even if I've already done this work on one side and I walk over to the other side and repeat this work, it feels a little different to my client. And that goes a long way, because even if we're technically doing the same stuff, this slightly different approach is going to access these muscles a little bit differently and allow the attachments to release a little bit deeper and allow the contraction of the muscle to let go a little bit better. I'm dropping down now from the superior aspect of the hip to the lateral aspect of the hip, and now I'm down inferior into the hamstrings. And I'm grabbing my thumb to create a nice broad point of contact and pushing the hamstrings up towards the pelvis to start loosening that fabric. And then what I want to do is sink into the hamstrings and stabilize them and create a little bit of friction into the IT band. The IT band, as you all know, is an incredibly strong band of connective tissue, and frictioning through here and creating warmth and creating some fluidity in this very commonly stuck structure can help to release this area as a whole. Oftentimes when I do deep work into the hamstrings, I'm thinking about sinking down through the bellies of the hamstring muscle and into the linea aspera, which is where the IT band comes and anchors into the femur, and also where the quad muscles anchor themselves in. So there's a lot of attachments really, really deep underneath the hamstring muscles that compressing down to a deeper level is going to start to release some of those attachment sites. And then as I sink up into the ischial tuberosity, in a similar way, I'm thinking about sinking down into the attachment sites yet again, holding this point as I lean up superiorly and using my left hand, which you can't see here, to hold the ankle down and offering an oppositional stretch throughout the posterior leg. I'm still not using any butter here, which allows me to really grip the connective tissue that runs all the way down the back of the leg. So as I use my right hand on the hamstrings and my left hand on the ankle, I'm pulling in oppositional directions, creating that nice stretch across the popliteal area, very specifically. There's a lot of connective tissue behind the knee. And then working more specifically up into the hamstrings themselves, I'm using my thumbs to pull apart these stuck tissues that run down between the bellies of the semitendinosus and the semimembranosus, and then on the lateral side, the biceps femoris. I'm about to start rolling out these muscles with my forearm, and as I do that, I want to reiterate that the pain that people feel that they sometimes refer to as sciatica is often something totally different. So I'm approaching all of this quote-unquote sciatic work as if your client might not realize that there's other things going on. So sciatic pain either comes from the piriformis or a pinching at the root of the nerve coming out of the spine, but there are a lot of dysfunctions that can show up with a hypercontraction of the lateral hip muscles or some fascial adhesions down the posterior leg that can feel like a pain that people associate with the sciatic nerve. So as you're doing this work, communicate to your client if any of this stuff is relieving. It's going to give you a lot more information about what's really going on for them. So at this point, I want to do some work that is more specific to the sciatic nerve itself. I'm compressing in through the glute max and down into the deep six and looking for the piriformis very specifically, but working my way around all of the deep six muscles and making sure that my work is broad as I start off and getting a little bit sharper and more poignant as I go. As I sink down into this area, it's really important to stay in communication with your client about what they're feeling and what it feels like when a nerve is hit as opposed to what it feels like when a trigger point is hit. This can be really tricky to describe to your client, but oftentimes I'll use the words a nerve feels electric and a trigger point, although it can feel radiating similar to a nerve, it has a more relieving quality to it. As you can see, as I start to sink in a little bit deeper, I'm using a broad forearm and then bending my elbow to find more specific points that are deep into the glutes. And like I was saying before, really staying in communication. When you sink down into this area, it is actually very possible to compress the sciatic nerve itself. And you don't want to do that. So as I bend my elbow and find that sharper focus, I'm reminding myself of the exact location of the piriformis, where it lies in relation to the sacrum, and thinking about those attachment sites and finding that soft tissue. I do not want to compress into the sciatic nerve itself. I think it's important, and I do this a lot where I kind of pause every once in a while and just remind myself of the anatomical structures. And as I sink back in, I'm actually going to compress down under the sacrum with a little more focus, but I don't want to do this with a sharp elbow. So my compression here is with my forearm, and as I bend my elbow a little bit, I'm just leaning into the angle of the sacrum as it pulls up away from the table, and I'm focusing my intention inferiorly. So using that compression into the sacrum to again make space in the lumbar spine and find some relief amongst all of these attachment sites. So if you're finding that you're sinking down into this tissue and it's not letting go, I love AETs. I think I've said this a couple times already. I want to engage my client and have them contract this muscle so that when it relaxes, I can sink in a little deeper. So as I sink into the upper glutes, I'm going to have my client lift her leg up off of the table, and I'll say to her, keep your knee straight and just lift your entire leg up a little bit off the table. And as she holds that contraction, I'm sinking down at a diagonal towards the table, but also towards her leg, compressing against a 90-degree angle into the upper glute tissues. And then as she relaxes, I sink down even deeper. And I can't emphasize enough how effective this technique is. So just a quick technique review. The glutes do extension of the hip. So as I sink down into the glutes, I have her do that specific action. And then when she relaxes it down, I sink in even deeper. I'm going to demo some work into the insertion of the glute max into the gluteal tuberosity on the posterior aspect of the femur, because a lot of what people can perceive as sciatic pain is actually some sort of adhesion or a firing pattern dysfunction of the glutes themselves. From sitting too long, driving too long, having some sort of more stagnant life can be really detrimental. So I'm going to wrap my hands around the greater trochanter and sink my fingers into the gluteal tuberosity, which is just lateral to the ischial tuberosity. And I'm going to sink down. I'm just going to lean into that and sink down and start to release a lot of the tension that often lives here. I can do an AET here as well. The glutes are also responsible for external rotation. So as I sink in, I'm going to have my client point her knee out to the side. This is external rotation. So the glute max is firing here. And then again, going back to what an AET does, when she releases it, I can sink down even deeper and start to release a lot of the dysfunction that can exist here. I'm going to repeat the same technique, but I'm moving up just a little bit. So I'm getting the lower muscles of the deep six. And as I sink down, she's going to do external rotation again. The deep six muscles are called the deep six lateral rotators because that's what they do. So as I sink down, she is activating all these muscles. I'm sinking through the glute max and down into the deeper aspects of where these tiny little muscles lie and helping them to let go. I've switched to an elbow just to show you another approach. This is a more aggressive approach for sure. So stay in communication, make sure you're not hitting that sciatic nerve, and make sure that the pain stays on the good side of pain and not the side that makes them maybe want to punch you a little bit. I'm about to demonstrate a pin and stretch for the piriformis, and I've demoed this before, but I just want to get into it with a little more depth. I'm picking my client's leg up because she's not really letting go of her hip, so I'm talking to her about letting her knee swing like a pendulum. And once she's finally letting go, I'm going to shorten this muscle, sink in, and stretch it out. So as you can see here, as I bring her foot towards her other leg, the muscle is shortening. The attachment sites of the sacrum and the greater trochanter are coming together, which softens the muscle. And then as I bring her foot away from her other leg, that's going to lengthen the muscle out. So the process here is to bring the foot in, shorten the muscle, sink down into it using my right hand, and as I'm sunk down, use my left hand to pull her foot out, which is going to lengthen this muscle out, keeping my compression down into this area and creating a nice pin and stretch. I want to point out that although this is typically demoed as just a piriformis pin and stretch, you can move around the posterior hip and really affect not just the piriformis but the glute max and the deep six. Depending on the depth of your work and where you place your hand, this is a great technique for this entire area. So I've got my client here in this position and I want to take advantage of that. So I want to do a little AET to incorporate with the pin and stretch I just did. I'm going to have my client push her foot out into my hand, so out away from her other leg. And as she does that, I'm sinking down, and I can sink down with either a soft fist or an elbow, again, depending on how much pressure your client can take and how aggressive this work needs to be. But once she's engaged, you sink down a little bit deeper, and then once she has released that, you can really create that pin and stretch on a whole nother level. While I'm here, I want to create a little friction around the attachment site of the glute medius. So the glute medius attaches onto the top of the greater trochanter. So you can see it right here. I'm anchoring my thumb down into that insertion point. And as I do that, I'm moving her leg into external rotation. You can really do internal and external rotation. This isn't really a pin and stretch as much as it is compressing down into the tissues and then creating movement and accessing these attachment sites from every different perspective. I'm about to bring my client's leg into a figure 4 position, which I love for working into the hip for so many different reasons. But I'm going to do a slightly different twist on it this time. So as I relax her leg down and bring her knee up, the thing that I'm going to do a little bit differently is that I usually bring the knee up pretty high towards her ribs and towards her torso, but this time I want to leave it down a little bit farther away from her side so that the deep six have a little more slack. I don't want to compress her hip up into her low back. I want to make sure that the muscles that I'm going to focus on while I'm here have a little more space and have a little more give so that if the sciatic nerve is in fact pinched, I'm not creating any more dysfunction than is already there. There is so much great work that you can do with your client's leg in this position, but one of the things that I think is most beneficial is reminding your client that the posterior hip is connected to the inferior hip, is connected to the medial hip, is connected to the lateral hip. And so what I'm doing here is really grabbing the top of the femur and I'm sinking my thumbs down into the lower deep six muscles that are coming in and attaching onto the greater trochanter and leaning into it and then pulling back to create some traction. Leaning in and then grabbing the whole femur and leaning back to create some space in the hip. Next, I want to create some mobilizations in the hip, and it's important to stay in communication about two things. First of all, I'm using my right thumb to compress down throughout all of the deep six muscles, working my way up methodically. And I want to make sure, like I said before, that I don't hit the sciatic nerve itself. So stay in communication about what feels good, what feels productive, and what doesn't feel good. And number two, make sure the inside of your client's thigh is not getting pinched on the table. So you can move your client closer to the edge of the table towards you and find a position that feels comfortable. But as you're doing this, you're sinking down, lifting the knee up to soften these muscles, and then pushing down a little bit on the knee to create length. So compression combined with movement, creating both a softening and a lengthening with this technique. Also, you might have noticed I started off with my thumbs and then switched to my fingers and then switched to my elbow. Just figure out what works for you and what works best for your client. Sticking with the theme of creating movement with the work in the hip, I'm sinking down into the softened TFL and the glute minimus, and as I sink in, I'm using my right hand to push the femur up. And what that does is it brings the attachment sites of these two muscles closer together, so as I compress in with my left hand, I'm also pushing down towards her feet and creating a little bit of space. So there's a combination of a shortening and a softening with movement of the internal structures that allows me to sink in a little bit deeper. This next stretch I'm going to do is a lateral rotation stretch. So I'm bringing her lower leg off the table and I'm using it as a lever. So my left hand is underneath the medial aspect of her knee and my right hand is pushing down on the lateral aspect of her ankle. I want to talk to her in this stretch about allowing her hip to release. And this can feel a little confusing to some people because it's something that most people haven't felt when they're on the massage table. So one of the ways to really get them to understand how to let go into this stretch is to engage them first and then push it down. So right now I'm having her push her ankle up towards the ceiling against my right hand, and then when she lets go, I'm able to really push her ankle down a little bit farther and enable this stretch to lengthen out all of the work that I just did into the hip and let everything kind of fall into place. So I've got my client in the side lying position and I'm about to get her to move her leg all around, but I want to isolate the muscles correctly. So I'm using my left hand to stabilize her hip and making sure that she's not engaging her abdominal muscles or her obliques. I want her to, as much as possible, isolate out the muscles that are going to extend the hip as I compress down in and do some work from this position. So I've got my left hand stabilizing her iliac crest and I want to keep it there. I'm using my right fist to compress down into the glute max and a little bit of the glute medius. She's lifting her leg up off the bolster, which is in front of her, and then extending it back towards me. And as she does that, I want to slightly push down, not just anteriorly, but inferiorly, making sure that when she contracts, it's not compressing up into her low back. And the firing patterns start to reset. So when she relaxes down, I sink in, and I give her hip some movement and settle all those muscles into place. I want to do the same thing for the glute medius, which lives right here on the lateral hip. So I'm going to sink in with my fingertips and I'm going to have her engage this muscle by extending her leg straight and then kicking up. One of the main actions of the glute medius is abduction. So as I sink in with my fingertips and have her lift her leg up off the table, I can really feel those fibers contract. And then when she relaxes down, I can sink in. And you guys know the deal. I'm sinking into a deeper level, creating a nice deep release within these fibers. And just because I always like to reinforce good body mechanics, you can do this same technique with your elbow. So as I'm sinking down, she's lifting her leg and then letting it drop back down and repeating that process. You can, if you want to, have her hold her leg up for about 5 to 10 seconds or anywhere in there and slow down this technique. If your client is feeling like this is a painful process, the slower option might be better. Or if your client is feeling like this is really working, the high repetitions might be a better choice. So as I work my way anteriorly on the hip, I just want to reinforce the global aspect of how all these muscles work together or against each other, and I'll talk about this a little bit more, but for now I'm palpating where the TFL is. My left hand is on the ASIS and my right hand is indicating the attachment into the IT band. So I'm curling my fingers around the front of the hip, and as I do this, I'm going to have my client flex her hip, and I can feel this muscle contract pretty immediately. So I'm going to have her flex and extend while I'm staying compressed in, and then once she releases down, letting her knee rest back on the bolster that's in front of her, I can do a little friction, I can do a little petrissage, but this muscle has eased up so I can gain a little more access. I'm going to demo one more alternate way to engage and sink into the TFL from this position. So again, I'm curling my fingers around the glute medius, sinking down into the front of the hip. I'm going to have my client extend her knee straight. Extend it straight. And once it's there, I want her to point her knee down to the floor. So this is internal rotation, and this is one of the main actions of the TFL. So when she does this, this is another active engagement technique, another way to mobilize this muscle, another way to sink in, and it's really effective. I definitely think this is one of those techniques that clients are really impressed with and actually creates a lot of change by isolating out this specific muscle. And then of course, as the femur rotates internally, all the other muscles around the back are feeling that effect and starting to loosen up. The other thing that I'm doing by focusing on the glute medius and the TFL and the anterior muscles very specifically is, if you remember the law of reciprocal inhibition, when a muscle is contracted, its antagonist, or the muscles that do the opposite of the muscle you're targeting, has to by nature relax. So as I'm working in the front of the hip, all the posterior muscles are relaxing a little bit more, and in this position I can take advantage of their relaxed state and guide the hip into a more open position. I have one more stretch that I'm going to demo before I get my client on the table under the sheets, and this one is for the front of the hip. So while she's side lying, I'm picking up her leg and I'm tucking her foot into my right hip, and I've got my right hand underneath her knee. I want to make sure that she's really letting go of her leg, dropping it down to the ground, and then once she does, all I'm doing is twisting my own body so that as I pull her knee back towards me, I'm leaning my left hand into her upper glutes to keep her lower back open and push the front of her hip anteriorly. This is a great counter stretch to all the work you just did in the TFL and can feel really great to the hip as a whole. Okay, I finally got my client actually on the table, and while I'm warming up her tissues, I'm just kind of repeating what I did over the close. I'm creating a lot of friction over the thoracolumbar aponeurosis, into the low back, into the sacrum, and down into the hip in preparation of sinking down a little bit deeper. I want to just mention, though, that all the work that I did with my client clothed is work that you can do either with your client on the table under a drape, or work that you can do in a session and then kind of halfway through, get them on the table, mix things up, make sure you're playing around with how to approach all of the stuff, and your client's going to feel very taken care of. Okay, now that I've thoroughly frictioned through and for all intents and purposes melted away the thoracolumbar aponeurosis, I can sink down a little bit deeper, and what I want to do is push the tissues away from the spine, allowing for, if there is indeed any impingement at the spine where the sciatic nerve exits, I want to offer some space. So I'm working from medial to lateral, sinking in right at the lamina groove and sliding across the fibers of the erector spinae, across the QL, and sinking down and creating space. There's a pretty notorious trigger point that lives right at the region where the ilium, the sacrum, and the lumbar spine converge. So in order to prep for that, I'm about to sink into that, I want to ensure that this area is opened up. So I'm doing a quick AET, I'm sinking down into the QL, I'm having my client hike her hip up, and I'm compressing down against that contraction. So it's a slight movement for my client, and then once she releases, I'm sliding over those fibers and just creating a deeper sense of release so that when I sink into that trigger point, I have a little more access. Okay, to find that trigger point, you want to make sure that you know exactly where the spine is and where the iliac crest is, and you want to find that space just above where those converge. If your client does indeed have a trigger point here, it can mimic sciatic pain like nothing else. So when you sink in, ask if there's a radiating pain, ask if they feel it down through the glutes, through the IT band. Sometimes it can travel all the way down to the back of the knee and down to the foot. Have them take a nice big deep breath. Hang out there until that point lets go. Once it does, you can repeat this process 2 or 3 times. Make sure that you make nice, but oftentimes this can be one of the most relieving techniques against what people perceive as sciatic pain. As I sink down into this point for a second time, I want to remind you that sciatica is one of the most overdiagnosed yet underconfirmed dysfunctions that people are convinced they have. A couple of indicators that will help you determine what's going on for your client a little bit better is that if they are indeed feeling anything all the way down into their foot, that's a good indication that the sciatic nerve is impacted. Or if they are feeling like the pain is a little more lateral, a little more vague, and travels around the leg in different patterns, that's a good indicator that it is not actually the sciatic nerve and there's a lot of other things going on that are creating a painful response, and your client knows the word sciatica and is hanging on to that as a way to describe the pain that they're experiencing in their hip and down their leg. So that trigger point that I was hitting up in the low back, and by the way, there's another one equally as poignant just below the posterior iliac crest, right into the top of the glute max. Both of those can radiate pain down into the hamstrings and into the IT band. And that radiating pain is the thing that a lot of people automatically assume is a nerve and then associate sciatic pain with that traveling sensation. So right now I'm dropping down into the IT band and I'm creating more friction, and I want to reemphasize the importance of what's going on structurally here. So the glute max and the TFL both come in and bleed into the IT band, creating this incredibly thick tendon. And this tendon doesn't just latch onto the lateral knee, but it also wraps around the back of the leg, dips underneath the hamstrings, and inserts itself into the linea aspera. So as it shares that attachment site with the quads, you can start to envision how all of these tissues coming in and crossing over each other is going to start to show up as adhesions and little patterns of stuck tissue that are going to follow this line down the leg from that initial trigger point in the low back. Following all of that logic, this is why I spend a lot of time sinking down through the hamstrings and into that attachment site in the back of the femur. I think this work is really important when it comes to hip pain and people who feel like they suffer from sciatica. I'm moving this work down into the lower leg and into the calf, and I'm continuing to focus my intention on the connective tissue that extends down from that low back through the IT band and all the way down through the Achilles tendon and into the bottom of the foot. Whether or not your client has true sciatica or pseudo sciatica or something that feels like sciatica, all of this work is really important and can often trigger a lot of relief for your client because of the relationship between the ankle and the knee and the hip. In order to keep that length going that I've started through the hip and the upper leg, I'm going to bring the lower leg off the table so that I can dorsiflex the foot. If you can see, her foot is on my thigh, and as I push her foot up into dorsiflexion, I'm creating more length through the Achilles tendon and through the gastrocs and the soleus. And I can also do this with a quick reciprocal inhibition. So if you remember, like in the hip, when we tell a muscle to contract, its antagonistic muscles have to, by nature, relax. So as she pulls her foot up into dorsiflexion, the muscles that do plantar flexion in the back, the gastrocs and the soleus, have to relax. I can take advantage of this knowledge, and as she creates that contraction in the front, I'm creating more length in the back. As I pull her leg back up on the table and rest her ankle on the bolster, I want to acknowledge the fact that this work has been really quick. For the most part throughout this video, my techniques have been fast, and there's a reason for it. There's a lot of connective tissue at play when we're talking about the attachments through the sacrum, through the SI joint, down the IT band, and then into the Achilles tendon and into the bottom of the foot. And connective tissue reacts really well to friction and heat. As I continue this theme down into the plantar fascia, I want to talk about thixotropy for just a minute. According to Wikipedia, thixotropy is when certain gels or fluids that are thick or viscous under certain conditions will flow or become thin or less viscous over time when shaken, agitated, sheared, or otherwise stressed. So kind of like taffy, if you let it sit, it's going to get hard and brittle, but if you soften it up, chew on it, warm it up, it's going to soften and become a lot more pliable. Connective tissue is thixotropic, so all of this friction does so much good. As we were filming this, my film guy was kind of like, I would punch you if you did any of this stuff to my feet. He was really ticklish. So for ticklish people, you want to slow it down, use a broader point of contact, and sink in a little deeper. So in the foot here, I'm grabbing the toes, I'm using a soft fist, and I'm slowing down what I'm doing and even switching over to just compressions. That can take that ticklish feeling away, and you're still sinking in and you're still creating change in the bottom of the foot. I'm bringing this work to a close and stretching out her calf and the bottom of her foot. And as I do that, I want to bring her awareness back up into her hip. So as I'm providing these last stretches, I'm talking to my client about how it feels compared to her other hip at this point, and if she can feel a greater connection down through the knee and all the way to the foot. People tend to walk through the world on autopilot. So when you bring their awareness to what their body actually feels like in that moment, that's a powerful statement about the work you're doing. And oftentimes they can really feel the difference from one side to the other before you move to the other side. So feeding them that information is not only a good practice for them and dropping them down into their own awareness, but it's also really good for what they're going to think about your work and the help that you are providing. For this last little bit, I'm going to expand on the straight leg test, which is a test for whether or not you want to see if your client actually has a sciatic nerve impingement. So lifting their leg up off the table, keeping it straight. If they pull their foot into dorsiflexion and at about 30 or 40 degrees of hip flexion, if they're feeling pain down into their foot, that's a positive test for sciatic nerve pain. But after you've done all of this work, this is also an incredible stretch for all of those tissues and can be a good reassessment to see if your client is feeling any improvement. So all I really did was lift her leg up in varying increments and have her pull her toes towards her knees at each of those levels. And I want to repeat this, but pull her leg out into about 20 or 30 degrees of abduction. That's going to put the sciatic nerve in a slightly different position and allow for a slightly different stretch. So traditionally, these moves have been used as a test, but they're also amazing stretches. You can employ them before you start the session and then do them again afterwards. Note any differences, point them out to your client, bring her awareness back down into everything that's going on, and remind her to stay dropped in as she gently gets up off the table and moves back out into the world.